بسم الله الرحمن الرحيم وبه نستعين. Assalamu alaikum everybody. This will be the last presentation about sympatholytics, and it will be about beta-adrenergic receptor blockers. This group of drugs, they have very important clinical application, especially on the cardiovascular system. So, as we have said several times before, the heart contains mainly beta-1 receptor, and as we have said, beta-1 adrenergic receptor, they are always excitatory. Why they are excitatory? Because they are linked to cyclic AMP through GS protein, and increase production of cyclic AMP, the second messenger, will increase the intracellular calcium, and this increase in intracellular calcium will increase all activity of the heart, including rate, conduction, and contraction. This we should know very well. So by stimulating beta-1 receptors in the heart, we will increase the intracellular calcium, and this increase in intracellular calcium will result in increase of all heart activity, including rate, conduction, and contraction. So this we should always remember. So what is the main goal of this lecture? The main goal of this lecture is to know the actions and the clinical indication of beta-adrenergic receptor blockers, drugs which block adrenergic receptor. First, we'll talk about the classification of the adrenergic beta receptors. All adrenergic beta receptors, all of them, they are competitive antagonists. Competitive antagonist at the adrenergic beta receptors. And we know what does it mean, competitive antagonist, i.e. they compete both beta blockers and noradrenaline, they compete on the same receptor, and whatever is present in higher concentration will take over the receptor. So beta blockers, they all are competitive antagonists at the adrenergic beta receptors. So how they differ? They differ in many properties, as we will see now. Okay. The first difference, how beta blockers they are different from each other. The first difference is in their selectivity. As we have said before, there are two types of adrenergic beta receptors: beta-1 receptors and beta-2 receptors. Beta-1, we said, are always excitatory, while beta-2 are always inhibitory. Okay? Therefore, there are certain beta blockers which are selective beta-1 blocker. Some of them, they are selective beta-2 blocker. Some of them, they are non-selective. Non-selective will mean they block both the beta-1 and beta-2. Okay? The beta-1 blockers actually, they have no clinical application. They have only experimental value. Which is important for us are the selective beta-1 blockers. This includes many examples. Maybe the most famous examples are atenolol, which is used, esmolol, which has a very short duration action, as we will see later, and acebutolol. Okay, so beta-1, selective beta-1 receptors, they are selective at therapeutic dose in blocking beta-1 receptors, and most famous example is atenolol and esmolol. Okay. Now, this selectivity, we have to point out that this selectivity usually it's not absolute. At high doses, These drugs, they can block beta 1 and beta 2, so they are only selective at low therapeutic dose. Okay. Non-selective beta blockers, which block both beta 1 and beta 2 receptors, the most famous is propranolol, which is very famous, propranolol, which is the prototype of beta receptor, propranolol, and it is commonly used, propranolol. Others, including timolol, which is used for treatment of glaucoma, and bindolol. There are many other examples, but these are the most famous examples. Okay, so the first difference between beta blockers and their selectivity. Selectivity, what does it mean? Some of them are selective to beta 1, including atenolol, the most famous, which is used in treatment of hypertension, and esmolol, and selective beta 2 blockers, which have no therapeutic application. Some of them, they are non-selective. They block both beta 1 and beta 2 at the therapeutic doses, and this includes propranolol, which is the prototype of all beta blockers, timolol, and bindolol. Okay, this is the first difference. The second most important difference between beta blockers is their lipid solubility. Lipid solubility. With lipid solubility, as we have discussed before many times, it determines the entry of the drug to the central nervous system. As we have said, drugs with high lipid solubility, they can penetrate the blood-brain barrier and they can have a central effect. Drugs which have a low lipid solubility, i.e. they are water soluble, they cannot penetrate the blood-brain barrier, and therefore they have only peripheral effects. Therefore, there are some beta blockers with high lipid solubility and some of them with low lipid solubility. Most famous example with high is propranolol, which is the prototype. Propranolol is the beta blocker with high lipid solubility. Therefore, we will expect that propranolol will produce peripheral and central effect. Beta blockers with low lipid solubility, we have examples like atenolol. Atenolol, as we have said, this is used very common in treatment of hypertension. It has low lipid solubility. And acebutolol. This is another beta blocker with very low lipid solubility. So we expect that propranolol, it has high lipid solubility, therefore it will have a peripheral and central effect, while atenolol and acebutolol, they will have only peripheral action. Okay. Third important difference between beta blockers is their local anesthetic activity. Local anesthetic activity. Local anesthetic activity, as we have said before, they decrease the activity in nerves through local anesthetic action. Maybe the most famous example is propranolol, which is the prototype, and as well acebutolol, Okay, so propranolol and acebutolol are beta blockers with local anesthetic activity. Local anesthetic activity is important because this means that these type of drugs, they can produce more depression of cardiac activity, for example, because they will decrease cardiac activity through local anesthetic action. Okay. The fourth important difference between adrenergic receptor blocker is the intrinsic, what's known as intrinsic sympathomimetic activity, intrinsic sympathomimetic activity, which is abbreviated as I.S.A, which means actually partial agonist activity. Partial agonist activity. We'll discuss it in a moment. Partial agonist activity. So somebody will say how it comes. They are blockers and they have partial agonist activity. We have explained that before when we talked about general pharmacology. These drugs, they will act as a partial agonist activity when the sympathetic activity is low. Low sympathetic activity. When the sympathetic activity, for example, to the heart is low, they will act as an agonist. I.e., if the sympathetic activity is low, that means heart activity is low. In this case, they will act as an agonist and they will increase sympathetic heart activity. Okay? And the opposite, if the sympathetic activity is high sympathetic activity, they will act as an antagonist. They will act as an antagonist. This is the property of a partial agonist, as we have explained before. We said that partial agonists, they will act as a partial agonist when the activity is low, and they will act as an antagonist when the activity is high. Okay? So these beta blockers with intrinsic sympathomimetic activity, I.S.A, they are partial agonists. What does it mean? That means at low sympathetic activity, when for example, the heart reaches low tone, in this case, they will act as an agonist and they will increase heart activity. If the sympathetic activity to the heart is high, in this case, they will act as an antagonist and they will decrease the heart activity. Okay? Maybe the most famous example is bendolol. Bendolol and acebutolol as well. And acebutolol. Acebutolol, it has intrinsic sympathomimetic activity. Bendolol and acebutolol. Okay? So this is the fourth difference. The fourth difference, which is important as well in the selection of the drugs, is their intrinsic sympathomimetic activity. Some drugs, they will act as a partial agonist when the sympathetic activity is low, and they will act as an antagonist when the sympathetic activity is high. In this case, these drugs usually they are reserved for patients with asthma. Asthma means sympathetic activity is low, bronchoconstriction. In this case, they will act as a partial agonist and they produce bronchodilation. And also they are indicated in cases where there is low cardiac reserve. Low cardiac reserve, that means cardiac activity is low. Okay? So this is the fourth important difference. Intrinsic sympathomimetic activity. Okay? The fifth difference is their first pass effect. Fifth difference is the first pass effect or first pass metabolism, as we have explained before. First pass effect or first pass metabolism. In that we said that these drugs, which are taken orally, usually they pass through the portal circulation to the liver first, where some drugs, most of it will be metabolized in the liver before it reaches the general circulation. As we have said before, the first pass metabolism will result in low bioavailability. In this case, we have to use higher doses of the drug so that to achieve therapeutic concentration in the blood. Okay? So, the first pass effect is important, and the most famous example is propranolol. Propranolol, prototype of beta blocker, it is exposed. Propranolol. It is exposed to first pass effect. Therefore, usually, because of this effect, we use higher doses when this is dangerous. When this is dangerous? Higher doses to achieve therapeutic blood level, to achieve therapeutic blood concentration, as we have said before. When this is dangerous, this is dangerous in people with liver diseases. People with liver diseases, that means they cannot metabolize the drug. So all the dose that is taken orally will reach the general circulation in higher concentration. In that case, it can produce toxicity. Therefore, propranolol, for example, dose should be reduced in cases of liver. Okay. Now, the sixth difference is the T-half. Most of them, they have intermediate T-half time. They act for hours. Like in very few of them, they have very short duration of action. Very short duration of action. Especially the most famous example is ismolol, which has a duration of action of minutes because it is an ester. It is easily hydrolyzed in the plasma. Ismolol. It has very short duration of action. That's why it is only used in intravenous injection in certain cases of cardiovascular disease. Ismolol, it has very short T-half. Why? Because it is an ester. It is easily hydrolyzed in the blood. Therefore, it will have very short duration of action. Ismolol. Okay. Lastly, some of them, they are non-selective. Non-selective. What we mean by non-selective? Adrenergic antagonists, they block both alpha and beta receptor at the same time. They block alpha receptor and beta receptor. Okay. Why they block alpha and beta? Because they are present as an isomer. One isomer block the alpha receptor and the other isomer block the beta receptor. Maybe the most famous examples are labetalol, most famous, labetalol, most famous, and carvedilol. So these usually they are used in condition to decrease both alpha and beta activity. Carvedilol and labetalol. Okay. So these are the difference between different beta adrenergic receptor blockers. Therefore, we said that the different selectivity, some of them they are selective beta-1 antagonists, and most famous atenolol. Some of them they are non-selective, and the most famous propranolol. Some of them they have high lipid solubility. For example, propranolol has high lipid solubility, atenolol has low lipid solubility. Some of them they have a local anesthetic activity, adding to their depressant effect on the heart. And the most famous example is propranolol. Some of them they have intrinsic sympathomimetic activity where they act as a partial agonist with low sympathetic activity, and the most famous example is bendilol. Some of them they have very short duration of action, for example ismolol, and therefore it is kept only for intravenous administration. Some of them they are exposed to first pass effect, and the most famous propranolol, which is exposed to first pass effect, and the dose should be reduced in cases of liver diseases. Some of them they block both alpha and beta receptors, and the most famous is labetalol. Okay, so these are the differences between the different beta adrenergic receptor blockers. So what are the actions? Now we'll talk about the actions and the clinical uses in the same time. What are the actions? So we'll talk about the actions and the clinical use. So first effect we are going to talk about are their effect on the heart, which is beta-1 effect. We said that the beta-1 effect on the heart is always excitatory. It will affect contraction of the heart. It will affect conduction of the heart muscle, and it will affect heart rate. Okay, all these three functions of the heart, they depend on beta-1 activity. Stimulating the beta-1 receptors will result in increasing the heart contraction, increasing the conduction through the heart muscles, and increasing the heart rate through SA node. Okay, conduction through AV node, especially from the atria to the ventricle, and rate through the I.S.A node. Therefore, by blocking the beta 1 receptor, that means we block all the activity in the heart. Will decrease contraction, will decrease conduction, and will decrease rate. These three actions, decreasing three, will produce certain indication and certain side effect as well. Okay? So therefore, by decreasing the contraction of the cardiac muscle, what will happen to the cardiac output? Will be decreased. So يحصل decrease in cardiac output. Okay? So cardiac output will be decreased because the force of contraction of the heart muscles will be decreased. Okay? This is one. If the cardiac output is decreased, that means what will happen to the blood pressure? Decrease blood pressure. Decrease blood pressure. This is one of the mechanisms responsible for the anti-hypertensive effect of beta blockers. So they are used as anti-hypertensive. This is the first indication. They use as anti-hypertensive because they can decrease the cardiac output, therefore they will decrease blood pressure. Okay. Now they decrease the heart rate, so they can produce bradycardia. Beta blockers, by blocking the I.S.A node activity, they will decrease the heart rate. They can produce bradycardia. Therefore, they can be used in cases of tachycardia. They are indicated in cases of tachycardia, which is known as tachyarrhythmia. Tachyarrhythmia. So this is an indication, and treatment of certain types of tachyarrhythmia. Okay, this is second application. As they decrease the conduction through AV node, that means that they can produce two things. One important and has clinical application, and the other is contraindication. Clinical application, they can block the conduction or decrease the conduction through AV node. That's why they are used in certain atrial overexcitability. As we know, conduction, most of the activity from the atria is spread to the ventricles through the AV node. If this activity is high, it can result in high ventricular activity, and high ventricular activity can result in lower cardiac output, and this is very dangerous. So beta blockers, they are indicated in certain terms of atrial overexcitability, i.e. they are used as anti-arrhythmic. Okay, they are used as anti-arrhythmic. Therefore, they are used for different types of arrhythmia. Arrhythmia means disturbance in the rhythm of the heart. خلل في نظم بتاع القلب. Okay, خلل في النظم ناحية الاستتارة الأكثر, towards more excitability. So in this case, if there is more atrial overexcitability, we use beta blockers because it prevents the spread of this atrial overexcitability to the ventricle. Also, they are used in certain types of tachyarrhythmia. This is another indication. Okay. Now, if they decrease the contraction, decrease the conduction, decrease the rate, it means that they will decrease the work of the heart. These three: decreasing the rate, decreasing the conduction, decreasing the contraction. What does it mean? It means the heart will work more or will work less? Of course, the heart will work less by decreasing the work of the heart. Heart will work less because contraction is less, conduction is less, heart rate is less. That means the work of the heart will be decreased. Decreasing the work of the heart means أن the heart will need less oxygen. معناها decrease the oxygen demand. Decreasing the oxygen demand. This decrease in oxygen demand is very useful, as we will speak inshallah in the future when we talk about ischemic heart disease. So they are indicated when there is ischemic heart diseases. Ischemic heart disease. Okay? So this is indication. They are indicated in ischemic heart disease, like in myocardial infarction, like in angina pectoris. Okay? So by decreasing the contraction, decreasing conduction, decreasing the rate, beta blockers will decrease the work of the heart. Decreasing work of the heart means the heart will need less oxygen. That means decreasing the oxygen demand. This is a very important indication in treatment of ischemic heart disease. Why? Why? Because as we know that there is usually a balance between the heart muscles between oxygen supply and oxygen demand. Okay? Demand, oxygen demand, they should be balanced. Whenever the heart needs more oxygen, the supply should be increased. Of course, the supply is done through the coronary artery, as we know. Coronary artery is the main source of oxygenated blood to the heart muscles. Okay? Now, when the oxygen demand increases in any situation like exercise, like mental stress, whatever, the supply should increase. The supply should increase. Okay? This is normal. This is the normal balance. Whenever the oxygen demand increases due to whatever reason, due to, for example, physical exercise or mental activity like stress or depression or whatever. In this case, oxygen demand will increase. Oxygen demand increase should be met with an equal increase in oxygen supply through the coronary circulation. واضح? Okay, now, if the oxygen demand is increased and the supply is not increased, stays the same, does not increase by increasing oxygen demand, what will happen? Disbalance. So oxygen supply will be less, with demand will be more. This will lead to what's known as ischemia, because the heart muscle will receive less blood supply, so it will suffer from ischemia. ischemia فقر في الأكسجين. ischemia. والischemia can lead to death to the cardiac muscle. Death of cardiac muscle. This is known as infarction. Okay? So, less oxygen supply will lead to ischemia, and this ischemia can lead to death of the cardiac muscle, which is known as infarction. This is known as ischemic heart diseases. Ischemic heart diseases. IHD. Ischemic heart disease. This includes two types. One is known myocardial infarction. Myocardial infarction, which we'll talk about them inshallah maybe in another 2 or 3 presentation, and angina pectoris. Okay, so beta blockers, they are very important drugs which are used in ischemic heart disease. Why? Because they decrease the oxygen demand, returning the balance to normal. Okay, So beta blockers on the heart, they have very important action and very important clinical application and contraindication. First, they can inhibit contraction, and therefore they decrease the cardiac output, and they can decrease the blood pressure. They are used as antihypertensive. They can decrease the conduction and decrease the rate, therefore they are used as antiarrhythmic in certain cases of cardiac arrhythmia. By decreasing the three functions, the contraction, conduction, and rate, they will decrease the work of the heart, and therefore will decrease the oxygen demand, and therefore they are used in ischemic heart disease. Okay. Another use of beta blockers is their use in congestive heart failure, where congestive heart failure there is a decrease in cardiac output. Beta blockers were found to decrease mortality and decrease morbidity. This effect we will discuss in details, inshallah, when we talk about drugs which are used in treatment of congestive heart failure. Other action of beta blockers is their action on the kidney. Kidney releases the hormone renin. Renin will act on angiotensinogen and will convert it into angiotensin 1. Angiotensin 1 will be converted to angiotensin 2 by the enzyme angiotensin converting enzyme. Angiotensin 2 is a local hormone. It will act on blood vessel on angiotensin 2 receptors, producing severe vasoconstriction. Also, it will act on the adrenal cortex to increase the secretion of aldosterone, corticosteroid, aldosterone, mineralocorticosteroid. Aldosterone will produce retention of sodium and water and excretion of potassium. This retention of sodium and water will increase blood volume, and this increase in blood volume will result in increase in blood pressure. Renin is under the effect of beta-1 regulation. Beta-1 will stimulate the release of renin. Stimulation of beta-1 receptors will stimulate the release of renin from the kidney. Therefore, by blocking beta-1 receptors, will block the release of renin, and in turn will prevent the synthesis of angiotensin 2. If we prevent the synthesis of angiotensin 2, will prevent its vasoconstriction effect and will prevent its increase of blood volume. That's why beta blockers are used as antihypertensive drug. For beta blockers, by inhibiting renin release, will prevent the production of angiotensin 2, and that's why they are used as antihypertensive drugs. This is another mechanism of action of beta blockers as antihypertensive. They decrease the production of renin from the kidney. Other effect of beta blockers on the bronchial smooth muscles, bronchioles. As we know, bronchial smooth muscles will depend on beta-2 activity, which is inhibitory, and beta-1 stimulation will produce relaxation of bronchial smooth muscle, and this will result in bronchodilation. Therefore, it is expected by blocking beta 2 receptor will result in bronchoconstriction. Of course, this bronchoconstriction will be more with the non-selective beta blockers, like beta 1 blocker and beta 2 blockers, like propranolol. This bronchoconstriction in a normal person is not that effective, clinically important, but it becomes clinically important in certain cases of obstructive pulmonary diseases, chronic obstructive pulmonary diseases like pulmonary emphysema, etc. This is known as COPD, chronic obstructive pulmonary diseases. As well, this bronchoconstriction, in this case, beta blockers, they are contraindicated. Bronchoconstriction can take place as well in bronchial asthma. It will make bronchial asthma worse, and that's why beta blockers should be avoided in people with bronchial asthma, especially the non-selective beta blockers. However, they said that beta blockers with intrinsic sympathomimetic activity, which we have said they act as a partial agonist, which are selective beta blockers, selective beta 1 blockers with intrinsic sympathomimetic activity, like albendazole, partial agonist activity, like albendazole. Albendazole, in this case, it might be a better choice if beta blockers are necessary to be used in people with bronchial asthma. Next effect is their effect on the eye, the effect of beta blockers on the eye. As we have said previously, beta adrenergic receptors, they are involved in increasing the production of aqueous humor in the posterior chamber of the eye. This increase in production of aqueous humor will increase intraocular pressure. This is dangerous, as we have said before, in cases of glaucoma. Okay. Now, therefore, by blocking beta receptors, will decrease production of aqueous humor, and therefore will decrease intraocular pressure. That's why beta blockers, they are first line in treatment of glaucoma. The most famous example is timolol, which is used as eye drops. Okay? So beta blockers, they are first line in the treatment of glaucoma. How do they do that? They block the production of aqueous humor, decreasing intraocular pressure. Why beta blockers, they are first line in this case? Because they have no effect on the eye accommodation. The next effect we will discuss is the effect of beta blockers on metabolism and on diabetes mellitus. As we know, sympathetic activity usually will increase production of glucose from glycogen through stimulation of glycogenolysis, and also to increase the production of free fatty acid from lipid by stimulation of lipolysis. Therefore, beta blockers, we expect that they will decrease glucose production and they will decrease free fatty acid production. This is most dangerous in cases of diabetes mellitus. Usually, diabetes mellitus are treated with anti-diabetic drugs. Anti-diabetic drugs. Most common side effect of anti-diabetic drugs that sometimes they produce hypoglycemia. They produce hypoglycemia. Hypoglycemia is a decrease in the blood sugar level below the normal value. Usually, when this takes place, when anti-diabetics they produce hypoglycemia, hypoglycemia will stimulate sympathetic outflow to the periphery. If the hypoglycemia is not treated, it can lead to coma followed by death. If hypoglycemia is not treated, can lead to coma and death. Usually this hypoglycemia normally it will stimulate the sympathetic activity. Producing anxiety, person will feel anxiety, increasing the heart rate, and producing tremor. These are the signs of hypoglycemia. In this case, the patient will know that he is entering hypoglycemia. So what he will do, he will take sugar in order to compensate for the low blood sugar. So this is very common with anti-diabetic drugs. They produce hypoglycemia. Beta blockers, if this person treated with anti-diabetic given beta blocker will block the peripheral signs of hypoglycemia. So the person will not feel the anxiety, the tachycardia, or the tremor. He will not know that he is entering into hypoglycemic stage. So what will happen? He will enter into slow hypoglycemia, coma, and death. That's why beta blockers should be avoided in people with diabetes mellitus and under treatment with anti-diabetic drugs. Okay? On diabetes mellitus. Next, we'll talk about their effect on thyrotoxicosis. Thyrotoxicosis is overactivity of the thyroid gland, which produces a huge amount of thyroxine and triiodothyronine, of course. Thyroxine and triiodothyronine, one of their effects on the heart, they increase the heart rate. They produce continuous tachycardia. Tachycardia. That's why usually beta blockers are added with other drugs. Antithyroid drugs, beta blockers are added to decrease the tachycardia induced by thyroxine. Usually propranolol is prescribed in this case. Okay? Next, their effect on the skeletal muscle. Beta blockers by blocking beta 2 receptors on the blood vessel which supply skeletal muscle. By blocking beta 2, as we have said, produces vasodilation and therefore we increase the blood supply to the skeletal muscle. We increase blood flow. Therefore, if we block beta 2 receptors, we decrease blood perfusion to the skeletal muscle, and this will produce sense of fatigue. The person will feel fatigue very fast. This is very common side effect of beta blockers. The person will complain of fatigue because of blocking of beta 2 receptors on the skeletal muscle will decrease blood supply or blood flow, and the muscle will get fatigue very fast. Next effect is their effect on central nervous system, and usually these central nervous system effects takes place only with beta blockers with high lipid solubility, i.e. they have the ability to penetrate the blood-brain barrier, and the most famous example is propranolol. Propranolol is, as we have said, it has a high lipid solubility, therefore it can penetrate the blood-brain barrier and can produce central and peripheral effect. Propranolol produces bad dreams or what's known as nightmares. These are very common side effects with beta blockers which have a central effect. The next use is the use of beta blockers in treatment of anxiety. It was found that beta blockers are helpful to decrease peripheral symptoms of anxiety. Including tachycardia, including a tremor, including increased respiration, etc. This use of beta blockers will help the patient to stay calm in situation needing mental alertness, as in the cases of oral presentation or oral exams. Most commonly used in this case is propranolol. The use of beta blockers in treatment of anxiety will be discussed in details, inshallah, when we talk about drugs which are used in treatment of anxiety. So, in summary, to what we have discussed today, we will say that all beta blockers are competitive antagonists. They differ in their selectivity, lipid solubility, intrinsic sympathomimetic activity, and local anesthetic activity. All beta blockers, they decrease cardiac function, decreasing oxygen demand, therefore they are indicated in ischemic heart diseases. They can decrease conduction, therefore they are indicated in certain types of cardiac arrhythmia. And they can decrease cardiac output and inhibit release of renin from the kidney, therefore they are indicated in hypertension. Beta blockers, especially the non-selective beta blockers, should be avoided or contraindicated in chronic obstructive pulmonary diseases and also in asthma. They should be used with caution in people who are suffering from diabetes mellitus because they can mask the hypoglycemic signs. They decrease the intraocular pressure, therefore they are used in glaucoma. Also they are used in thyrotoxicosis and anxiety. Beta blockers with central effect or high lipid soluble beta blockers, they can enter the blood-brain barrier. They can enter the brain and cause nightmares. They can cause also cold extremities and fatigue. By this, we have finished talking about autonomic nervous system and drugs acting on the autonomic nervous system, including the parasympathetic and sympathetic nervous system. And by the next lecture, inshallah, or the next presentation, we'll start talking about drugs which act on the cardiovascular system. I would like to thank you very much for your attention. If you like my presentation, please don't forget to press like. If you have not subscribed to my channel, please subscribe. I hope that you stay in good health, in harmony, and prosperity. I wish you all good luck. Wassalamu alaikum wa rahmatullahi wa barakatuh.